Hey coders, welcome to Hot Takes with Codehead, where we're going to talk about some of the gray areas of medical coding and my take on them. I am a coder, auditor, and physician educator with more than 10 years of experience with a passion for medical coding. I believe that coding is an art, not a science. I think that even though the AMA and Medicare give us guidelines to go by, I do think that coders can interpret these guidelines in different ways. Today, my hot take is that I don't think that every new problem a patient has is an undiagnosed new problem with uncertain prognosis. Before I explain why I feel this way, let's back up a little bit and just make sure we're all on the same page. So what we're talking about is evaluation and management services. These are services that are performed by physicians when they see patients in a multitude of settings. It could be the office, the hospital, ER, a skilled nursing facility, home visit. These are just a couple of examples of when these codes would apply. So evaluation and management services, the level of service is determined two ways, either medical decision making or time. Let's talk about medical decision making. Medical decision making is made up of three separate elements: the number and complexity of problems addressed at the encounter, the problem type, amount and or complexity of data to be reviewed, this is data, and the third element is risk of complications and or morbidity or mortality of patient management. So this is the risk element. So we have three separate elements, and the level of medical decision making is determined by two out of the three elements. It doesn't have to be all three. So we're talking about the first element of medical decision making to answer our question, which is the number and complexity of problems addressed at the encounter. So in 2021, when the new E&M guidelines came out, the AMA had a multitude of definitions included within the guidelines to define different types of problems. And initially, when these guidelines came out, they did have some examples which were very helpful. However, since those original guidelines came out, they have since removed the examples. So of these definitions that they provide within the guidelines, they have an undiagnosed new problem with uncertain prognosis, and it's defined as a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment. In the original guidelines, the example that they provided was a lump in the breast. Again, this has been since removed. However, it does kind of provide us an example, even though it's no longer still officially in the guidelines. So when I read this definition, I see that this type of problem has to have two things. It is a problem that could have a differential diagnosis, and it has to be a condition that is likely to result in a high risk of morbidity without treatment. So I think those are the two key factors. I feel that not every type of problem a patient could have, especially in certain specialties like maybe family medicine or pediatrics, I just don't feel that that could represent every type of new problem that these patients could have. First Coast Service Options is a Medicare administrative contractor. They have kind of expounded on this definition. They have included the AMA definition, but they've also added this part right here. Documentation must support the new diagnosis and how the problem is likely to result in a high risk of morbidity without treatment. A patient may have a new problem that could fall into one of the other categories, such as a sinus infection. This supports my theory that not every single problem is an undiagnosed new problem with uncertain prognosis, which is a moderate level problem. I work in nephrology, and an example that I really feel like fits within this category of an undiagnosed new problem with uncertain prognosis would be a situation where a patient has been referred to a nephrologist due to elevated creatinine. Essentially, this means that the patient's kidneys are not functioning the way that they should. And in this situation, the nephrologist, they are going to review labs. They're going to order a bunch more labs. They could possibly do a renal biopsy or a renal ultrasound. And in these situations, the provider is really trying to work up the patient in order to determine what exactly is going on with their kidneys. So I do think this kind of fits within the category of a differential diagnosis. I also feel like this could represent a high risk of morbidity without treatment, because if a patient's kidneys are not functioning properly, this could lead to a situation where a patient would need possibly a kidney transplant, or they would need to start dialysis, either of which could result in a high risk of morbidity to the patient. So in my opinion, this is an example that fits within the specialty I work in. That said, based on the AMA guidelines and the guidance from First Coast Service Options, I don't feel that every single problem that a patient has that is new is necessarily going to fall within this category. I think some of them could be a lower level problem. All right, coders, here's my bonus hot take. I don't think chronic kidney disease stage 4 is automatically high in the number and complexity of problems addressed at the encounter element of medical decision making. Let me explain why. There are two types of problems that are considered high in the number and complexity of problems addressed at the encounter element. The first one is chronic illness with severe exacerbation, progression, or side effects of treatment. The severe exacerbation or progression of a chronic illness or severe side effects of treatment that have significant risk of morbidity and may require escalation of care. Reading this definition, I don't think this is always going to encompass chronic kidney disease stage 4. There are some patients that have chronic kidney disease stage 4 and they could be stable. They could be stable for the last 6 months, or maybe they're fluctuating between CKD stage 3B and CKD stage 4. I think if a patient has chronic kidney disease stage 4 and they are stable and they're just doing routine labs, routine follow-up, I don't think it necessarily falls within this category. The second type of problem that qualifies as high in the number and complexity of problems addressed at the encounter element is acute or chronic illness or injury that poses a threat to life or bodily function, and it's defined as an acute illness with systemic symptoms, an acute complicated injury, or a chronic illness or injury with exacerbation and or progression or side effects of treatment that poses a threat to life or bodily function in the near term without treatment. Some symptoms may represent a condition that is significantly probable and poses a potential threat to life or bodily function. These may be included in this category when the evaluation and treatment are consistent with this degree of potential severity. When I hear this definition, I think the key things to me are it poses a threat to life or bodily function in the near term without treatment. I think that patients, again, who have chronic kidney disease stage 4 and it's stable and the physician is just telling the patient just follow up as you usually would, to me that doesn't necessarily meet the criteria for this condition. I think that it really depends on the context of the scenario, what the provider's documentation is, that really kind of helps to determine where a problem kind of falls within this particular element. And I don't think it's a good idea to make a blanket statement that if a patient has X diagnosis, automatically it falls within this category. I think that the intent of the guidelines is really to paint a complete picture of what's going on with the patient and not merely checking off boxes. I don't think that that's the intent. So in my opinion, I don't think CKD stage 4 is always going to be high in this particular element. I think there's a little bit more to it than that. Again, this is just my hot take on this. I hope that you've enjoyed listening to me talk about my different hot takes on some medical coding issues. I'm sure some of you may agree, some of you may not, and I encourage you to put your comments in the comments below. I'm happy to have a discussion about this. Navigating the gray areas of medical coding can be challenging, but we're all in this together. Stay sharp, coders.